maniera più chiara la dinamica per cui quei 18 pazienti trattati da medici alle prime armi diciamo, sono dati incontro a un suicidio. Ecco, cioè io vorrei sapere la dinamica per cui questi pazienti trattati in ipnosi si sono suicidati.
Si è accentuato loro il desiderio di suicidio.
They were not students, they were psychiatrists. This was I don't have the details of the study. It was a study reported through the American Psychiatric Association. It was a study done several years ago in one of the states in the United States, in which a sampling in a Midwestern state of psychiatrists with limited training in hypnosis of 1 week were followed in terms of their using hypnosis in their practice. And in 1 year, in this group of 40 psychiatrists, there were reported 16 suicides and approximately 40 episodes of psychoses. But this was a report in the Journal of the American Psychiatric Association, and they did not convey the details of that study, so I do not have access to it. But I will try to get it for you if you like, and if you will leave me your address, I will mail a copy to you. I would be glad to do that. But they were not students. That was a different study I was referring to.
Ho fatto questa precisa domanda perché 5 anni or sono si è presentata da me una paziente affetta da nevrosi con somatizzazioni. La paziente è stata trattata e ha avuto anche buoni risultati. Superato un periodo di circa 2 anni si è di nuovo ripresentata da me e desiderava di nuovo essere trattata per qualche altro disturbo. Era un po' depressa. Ho fatto un trattamento di ipnosi e la cliente si è sentita abbastanza bene, se non che una sera è rientrata d'urgenza verso le 11 di notte, piuttosto sconvolta, in uno stato di crisi depressiva. A quel punto ho ritenuto non fare alcun trattamento e ricoverarla immediatamente in un ospedale neuropsichiatrico per un trattamento d'urgenza. Il giorno dopo ho saputo che la donna si è suicidata, ma si è suicidata in maniera violenta applicandosi la benzina addosso. È morta come un bonzo, insomma, come bonzo. Quindi un po' questa dinamica, questo approccio con l'ipnosi in soggetti depressi, particolarmente depressi. Ecco, il motivo è questo, volevo sapere quale poteva essere la dinamica scatenante per cui la paziente si è ridotta a questo stadio. Grazie.
I understand the question more clearly now. I think one can infer the dynamics without knowing them in this case, or in these cases. I do not have the feeling that the use of hypnosis on the part of the psychiatrists mentioned in the study by the American Psychiatric Association, I do not feel that the use of hypnosis necessarily was a precipitating factor either in the psychotic episodes or in the suicides, but rather was the poor clinical judgment and the incompetence of the therapists in evaluating the totality of the case and using strategies with hypnosis which they could have equally done without hypnosis. And I'm sure that they have a higher incidence of trauma with their patients without hypnosis as well as with hypnosis. Because, and I'll cite a little material before I go on with the other issues this morning, one can use hypnosis with very disturbed patients without precipitating psychotic episodes and without precipitating suicidal attempts. In fact, many years ago, about 1948, Wolberg, in treating schizophrenic patients with hypnotherapy, said that hypnosis is an ego-supportive device with severely disturbed patients, and that there were no untoward reactions. And others, Dr. Biddle, who is the director of the Philadelphia State Psychiatric Hospital, wrote a book on hypnosis in the psychoses, and that psychotic patients can be treated safely with hypnosis in a supportive way. I think in the study that I made reference to, it was the kind of tactics and the strategies they employed and their total relationship that precipitated the dynamics of those suicidal acts and those psychotic episodes, not the use of hypnosis per se. Because, for example, in the study I referred to earlier this morning, these were 50 patients who were assigned to 5 graduate students who were trained in hypnosis, and they had no therapeutic skills whatsoever. And what happened is this. Let me describe the kind of case that was seen, which I think is related to your question in a way. This was a 34-year-old married woman who was first seen while still a patient in the state hospital following a suicide attempt. She had been in psychotherapy for 2 years for a washing compulsion, which so preoccupied her daily life that she was unable to assume any responsibilities for the family. In her most recent analytic therapy, she had spent a good deal of time discussing and uncovering apparent sexual origins for the need to be clean and to wash as many as 20 to 30 times a day. She was unable to touch her hair without feeling that she was kidnapped.
Riprendere da prima,
Oh, all right. I will start again. This was a 34-year-old married woman, first seen while still a patient in a state hospital, following a suicide attempt. She had been in therapy for 2 years for a washing compulsion, which so preoccupied her daily life that she was unable to assume responsibilities for her family. In her most recent analytic therapy, she had spent a great deal of time uncovering apparent sexual origins for the need to be clean and to wash as many as 20 to 50 times a day. She was unable to touch her hair without feeling she was contaminated. And any contact with other people or even objects would require frequent hand washing, as well as long periods of showering and bathing. She was assigned, and the reason I'm citing this one case simply is that this is obviously a very disturbed woman. And yet we decided, because of her lack of success and because of the nature of this research study, to assign her to an experimental therapy project, which she did not understand to be therapy, but simply training in hypnosis, by graduate students, not therapists, who simply were going to treat her with relaxation. She was in therapy for 3 months with this experimental group. Hypnosis was employed primarily to produce relaxation and to eliminate the need for barbiturates and tranquilizers. She was taught self-hypnosis for insomnia, and to reinforce the relaxation. Hypnotic sessions would vary from 1 to 3 hour periods, never less than 1, sometimes as long as 3. During this time, since it was a research investigation, it was possible to take polygraph readings of her respiration. And it was noted that the muscle tonus would grow completely relaxed, both thoracic and abdominally. The patient could remain immobile for the entire session. There was no attempt to elicit information, no attempt to elucidate any affect or any ideation. There were no suggestions given except for relaxation and for being very quiet and very calm. During this period, nevertheless, the patient described spontaneous images, and she was encouraged, and this was the only suggestion she was really given, she was encouraged to visualize herself as she would ideally like to be. A concept many of you are very familiar with. In effect, we were asking, or the student was asking her to develop an idealized image of herself, the ego idealization, and to focus on the idealized ego state. And she did this, and she described those things which made her feel joyful and pleasant, and she said free of all those contaminating and dirty associations. During the 3 months, and towards the latter part of the 3 months, she began to feel free to touch herself in a normal way, to brush her hair. She was able to touch other people for the first time without wearing gloves. She began to travel in subways and buses. She began to socialize for the first time in 4 years. Her depression diminished, and she began to think seriously about going back to work. She finally did. She enjoyed her children, and she began to assume a normal life experience. The total treatment was 4 months. The only importance of this was in relation to the theoretical issue that hypnosis has some stabilizing homeostatic qualities that are unique to it and are not dependent necessarily on the skill of a clinician engaged in therapy. On the other hand, somebody more skilled in therapy who will do things that are inappropriate for the patient's needs, as in the study from the American Psychiatric, can precipitate untoward reactions. So that hypnosis as a stabilizing homeostatic experience obviously is a constructive one and may by itself, in cases where individuals are very refractory to treatment and unresponsive, produce on what we would describe a simplistic level, but not really so simplistic, because it is more basic than simplistic, can produce stabilizing results very similar in concept to what I described with diabetic patients, where blood glucose levels can be stabilized simply as part of the hypnotic relationship and the hypnotic alliance. And much of the dynamics, as well as in diabetic patients, the physiodynamics become homeostatic. I think there is a concept which runs not only in relation to emotional disorders, but has its concept in relation to the whole nature of the physical universe, in a sense. Dynamic equilibrium. I think very much using the concept of a digital or analog computer. If a computer is poorly programmed it is not going to function very well. Human beings are made up of many segments and many modules, and if the programming goes awry, there's going to be malfunction. If one can create dynamic equilibrium, and I think relaxation, hypnosis, psychotherapy, other procedures move in the direction of creating some dynamic equilibrium within the individual, different for each individual, but it maintains a dynamic state so that it is not precarious. In these cases, and this was only one that I described, these were very disturbed people who had not benefited from psychotherapy, who had not benefited from psychopharmacologic therapy. But here they benefited from a apparently simple procedure. Again, the only point I'm really making is, it is not as simple as appears. It is not as simple as meets the eye. And that we are dealing with an element that has a stabilizing influence for many individuals. But again, it's a matter of selectivity. For some, it will not produce such reactions. And I must say, not everybody who was referred to this project responded as well. Some we terminated within a few sessions because it was not working well. They were not stabilizing. They were becoming more uncomfortable. They were asking too many questions. They were being disrupted. But with the proper selection, and again, going back to your question, the dynamics have to do with the careful selection and the diagnostic assessment of the individuals involved, in which case any therapy, but particularly hypnosis, can at very basic levels become very effective and produce very meaningful results.
Ecco, a proposito di questa...
Microfono.
Ah, sì. A proposito dell'incidente dei, diciamo così, inizianti la terapia appunto l'ipnoterapia, devo ricordare, ed è utile, la recensione fatta dal periodico Federazione Medica, organo degli ordini dei medici d'Italia, nel 1971, del mio volume Psicosomatica e ipnoterapia, nella quale recensione è messo in rilievo che io dotavo gli studiosi di quelle cognizioni di psicologia e di altro genere affine che mettevano i medici e gli psicologi nella situazione di poter evitare di cadere in eccesso di interpretazione organicistica della malattia del soggetto, di evitare l'eccesso di organicismo. Per quel che riguarda la lupofobia, devo confermarvi che è una peste anche qui, estremamente difficile a correggere e a risanare. La nostra esperienza ci informa che si tratta di un disturbo profondamente radicato e anche ha una causa che sfugge alla ricerca nella personalità, così che fa sorgere il dubbio che si tratti di un patrimonio genetico oppure di un patrimonio genetico per effetto del quale il soggetto considera la purezza del corpo e del io con una ossessività talmente prepotente da resistere a qualsiasi trattamento, sia come si chiama? Sia anche al trattamento mediante paradosso ridicolizzante. Ecco, questo, seppure con parole un po' impacciate, è il concetto che volevo esporre. Ecco, grazie.
Allora, brevemente, scusate, prima di tutto devo chiarire un equivoco. Io ho detto che vado in pensione, ma intendiamoci, vanno in pensione le attività internazionali. Io continuo a lavorare, cioè mi occuperò di attività internazionali a ritmo molto ridotto. Ad esempio, sono stato invitato dall'11 al 13 novembre a partecipare a una riunione del Consiglio o verde, rispettivamente, colori rilassanti e i colori dominanti nel creato. L'azzurro dei cieli e dei mari, il verde della vegetazione e anche dei mari talora. Dopo 15 o 20 minuti il paziente si trova già meglio predisposto all'induzione in ipnosi. L'intensità della luce viene graduata mediante apposita manovra.
Briefly, but I would rather deal with a summarization of the various applications of hypnosis later this afternoon as part of our summary of all of the events that are taking place in the United States at the present time. However, one of the points that Professor Markuson brought up is of interest in terms of what we were talking about before. There are two kinds of resistances that obviously coexist in relation to hypnotizability. One may be a resistance which has its origin in some neuropsychological mechanism. And that's really what I wanted to get into at this point after the break, and what I referred to yesterday as the alexithymic problems in terms of the function of the right hemisphere as opposed to the left, where the left hemisphere is essentially linguistic and verbally mediated, and where the right hemisphere is much more concerned visuospatial, perceptual, emotional, and imagery aspects. But I think this verges on the question that was implied in Professor Markuson's questioning. It has been found that if you take the alpha rhythm of a patient's own electroencephalographic record, and if you will drive that alpha rhythm at that amplitude directly back through a television cathode tube, that you will produce a state of drowsiness, and that it will move into a hypnagogic state. During that hypnagogic state, it is possible to intervene and frequently produce a hypnotic situation. I think that kind of mechanism, neuropsychologically and neurophysiologically, has to do with hemispheric function and fusion, whereas most resistance to hypnosis, I would have a feeling, is a psychodynamic factor and has to do with the effective elucidation of the hypnotic relationship rather than with brain function. But there is an important area here which Professor Markuson made reference to, and I think it refers, in terms of alpha rhythms and other aspects of the EEG correlates, to the ability either to fuse or not to fuse the right with the left hemisphere. And I would like to present some material now, as I promised earlier, which deals with the use of hypnosis with a group of patients whose nosology or diagnostic entities cross many lines. They include borderline patients, they include those patients with severe neuroses, they include patients with depressive reactions, they include a large number of patients with somatization disorders. The diagnosis is not the issue, because alexithymia is not a diagnostic entity, but it is one that has been studied very extensively in the past number of years in the United States. And it refers, in essence, to individuals who obviously cannot relate proper language formation, cannot find, in fact, the literal definition of alexithymia, which incidentally was first studied in France and later adopted as a major interest in the United States. The alexithymic definition and process is that the individual cannot find the appropriate and meaningful words to describe the feelings that are going on. They can describe the distress, but that is simply topological description. They cannot describe and adequately explore the words, the language that refer to the feeling. These are also individuals who report usually very few dreams that are retrievable. In studies of alexithymic patients in sleep laboratories, they also have very few dreams. In other words,